Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. Welcome to the second day of the Combined Gulf Cancer Conference. I would like at the beginning to thank all the organizing committee, especially Dr. Ali Al-Zahrani, Dr. Saleh Al-Uthman, for putting such very challenging, very much needed conference during this challenging time. Especially most of our conferences are related to COVID-19, but this one is addressing the cancer, which is a work that we really need to emphasize during this difficult time. I must say yesterday, Alhamdulillah, we had a record registration of almost 1,500 and looking forward for more interactions with today's interesting program, including artificial intelligence, research, and the role of NGOs. So we'll start with our first sessions, which is the role of innovative and artificial intelligence in cancer control and management during distress time. It gives me a great pleasure to introduce our first speaker, someone I know very personally. I'm glad that I met her, Dr. Nadine Hachach-Haram. She's a plastic surgeon, and not only a plastic surgeon, she is interested in innovations, education, global surgery. She has been awarded or recipient of the British Empire Medal by Her Majesty the Queen of England for innovative work, as she is a co-founder of artificial intelligence platform Proximie. And I think with the work she's doing is we are going to reshape the future of our healthcare delivery, especially surgery. So without any delay, Dr. Nadine, please go ahead.
Thank you, Dr. Mahmoud, and I want to really thank you for inviting me to join you on such an important topic and such an important conference. As you very kindly introduced me, I am a reconstructive plastic surgeon, largely focused in the areas of cancer reconstruction, so breast and pelvic cancer. I'm based at Guy's and St. Thomas's Hospital in the United Kingdom, but I've also been very passionate about how do we draw an intersection between technology, innovation, healthcare to ultimately try and drive better care for our patients. Of course, COVID-19 has thrown a spanner in the works, and we've had to really think hard about how do we continue to deliver cancer care and surgical care to our patients. I would like through this talk to share with you initially my journey about how I set up Proximie and why, and then the role this has played in COVID-19 and how I hope this can continue to extend across the Gulf as well. Of interest, of course, I spent my childhood in Saudi Arabia, so I'm very familiar with the Gulf, and it's a very dear place to me as well. As a practicing surgeon, I've been a surgeon now for over 10 years in the UK. One of the key fundamental components that used to frustrate me as a surgeon was this considerable variation in quality and care. Why is it that patients who go to one hospital have a very different experience than patients who may go to another? But equally, when I was training, why is it that only if I was able to visit certain hospitals could I get this wider experience? And if that luxury wasn't bestowed on me, I was limited to only the experience available within my unit or within my center. I got involved a lot in global health. I spent about 10 years traveling to different parts of the world to look at sustainable models in surgical care. And I also worked a lot for the device industry, trying to understand how new products come to market. How do we train doctors and surgeons on these new products? And how do we make sure we do it in a way that's safe and effective? And I think ultimately I recognize that there's always a bottleneck. Unless two surgeons or nurses or clinicians or healthcare workers are standing together in the same room, that transfer of knowledge can't happen. And so I started to think that if we're able to save lives by combining the best of human expertise with the most advanced technology, could this change the way we do things? But of course, we need to take a look back and understand why surgery is the way it is and look back to our history. And of course, this picture from several hundred years ago demonstrates that surgery, the genesis of surgery, was very much around communication, collaboration, and co-presence. That if we were all standing in a place together, we could drive new techniques, we could drive better care for our patients, or we could share great ways that surgeons are doing things. Fast forward to 18 months ago, what's clear is that we haven't adapted our models to the fourth technological revolution. We're still doing the same thing. We're just putting more people in an operating room. And maybe not as many as in this picture, but I assure you this is a real picture from Texas in a cardiac procedure. but the idea that we all have to be there in that room together in quite a passive way. And I'm sure you'd agree that, you know, there's a very high risk that a lot of these individuals who are watching are going to go back to their hospitals and maybe would have picked up about 60% of what needs to be done and learn their way through some patients on how to do the rest. I was very honored a few years ago to be asked to be one of the main commissioners on the future of surgery. This was a white paper written by the Royal College of Surgeons that really tried to identify what surgery will look like in the next 5, 10, and 15 years. We were trying to understand, are we going to reshape surgery? Is it going to be different for the future? And we demonstrated through this paper, which is available online and you can access it, is that the future of surgery is digital. It's engaging, it's immersive, it's data-driven. And a number of different technologies will play a role there. Computer vision, robotics, artificial intelligence and machine learning as we drive insights back into the operating room. Big data and genomics through precision medicine. And these things we're already seeing, of course. And of course, visualization with augmented reality and virtual reality. Ultimately, what we're saying is we want to move an operating room, which I'm sure you'd agree is a very analog environment, very manual. Everything is still done by paper and pen to some extent, or disconnected technology or electronic systems to more digital. And so I would ask you to join me on this vision or journey of digitizing the global operating room and how perhaps we could shape a network of operating rooms all connected around the world to collaborate and to share expertise and to deliver care to patients. Of course, ultimately, and I'm sure as a clinician and all of you as healthcare workers would agree, is that this has to be for value though. The last thing we need is more technology for the sake of technology. We're looking for technology that's going to either improve outcome, reduce cost, or do both. And this was Porter's example from Harvard, looking at what's value-based healthcare in our systems. But when we look at variation, perhaps we need to take a wider step around variation, because when I used to stand and give this talk in other conferences, the feedback often used to be that variation in care is really a problem for the low and middle income countries. But I can tell you with confidence and anchored in evidence that variation is a problem across the world. And these numbers are actually from papers that were published about the US and about Europe. In Europe, for example, and in the UK, you're 14 times more likely to suffer complications following surgery for colorectal cancer between one hospital and another. In Germany, you're 9 times more likely to have revision surgery following vascular surgery for the aorta. In Sweden, you're 36 times more likely to have complications following cataract procedures. And so this is a problem that we need to think about. And so what I'd like to share with you today before we jump into the impact in cancer is my vision of what a digital operating room should look like and the multitude of technologies that we've brought together to try and solve this problem.
Imagine a world where the quality of healthcare you receive doesn't rely on where you live. Everyone should have access to the best clinical expertise, no matter where they live on the planet. If a surgeon is operating on a complex procedure on one side of the world, why can't she collaborate with an expert surgeon on the other side of the world, live in the operating room? The clinical world needs to innovate, and it is. The age of telehealth is well and truly upon us, with Proximie leading the way.
So what's the answer? Remote surgery.
We're on a mission to save lives and connect the best medical clinicians on the planet to a mixed reality technology platform that combines artificial intelligence and augmented reality with real-time communication, allowing a clinician to virtually scrub in from anywhere in the world at any time.
The fact that I can see you perfectly, I can hear you perfectly, and I'm literally in the middle of practice clinic on an NHS Wi-Fi.
An expert surgeon can now virtually transport himself into any clinical setting simply by using his phone or tablet or computer. And he can visually and practically interact in an operation from start to finish, guiding and mentoring a local doctor through the procedure step by step. Through devices of the future, we can really do miraculous things.
Plug in Proximie. Connect clinicians. Save lives.
And so really what we wanted to build was a robust solution that was scalable and accessible, that enables clinical collaboration and skill transfer, supports the sharing of expertise, and can be used by clinicians all around the world. The idea was that if we really want to digitize the operating room, we have to address some key fundamental needs. First and foremost is communication collaboration. The platform needs to allow us to deliver a strong level of communication with ultra low latency and low bandwidth requirement. And we need to be able to take up to 4 feeds to be able to make that interaction immersive. The second is surgeons like to demonstrate. We like to gesture, we like to draw, to show what the steps of the procedure need to be. So having that multi-sensory experience with visualization and augmented reality is key. And finally, it's how to become data-driven. If we're able to aggregate this data and information, build actionable analytics that we can feed back into the operating room, how useful this will be for the surgery of the future. And we'll show you some pictures on that soon. And so the solution has 2 key components. It has the live environment, where many surgeons can dial in either to learn or to collaborate or to share their opinion on how to move forward with the procedure. But then that interaction can be recorded into a library if they choose to have it recorded. It's fully HIPAA and fully GDPR compliant. It's hosted locally within sets within the Gulf, and it's fully safe to have as your own library of cases that you can use for learning and education and for case review. Having the augmented reality is so critical because you can layer anatomy and images and scans onto the operating view and demonstrate anatomical landmarks and how to proceed through an operation. This is something we do regularly. It's something I do in my practice when I'm preparing for my flap reconstruction. But also it has to be easy and seamless. As surgeons, we are impatient. We don't want things that take a long time to train on. You can see here, the surgeon is sitting at his own personal laptop and he's working with his fellow who's operating in a room 3 floors down. He's able to just interact with her, help her through the operation as he's running a parallel list or a clinic, building efficiency, effectiveness, and quality control within the system. But this surgeon could also be 5,000 miles away, as we have many examples of. But at the core, what we're trying to do is to change our model of surgical care from see one, do one, teach one, to prepare, perform, and perfect. This notion of see one, do one, teach one really is archaic, disconnected, siloed, and undigitized. But if we can move to prepare, perform, and perfect, it means we contain a continuum supporting career-long learning. Preparing by watching other surgeons all around the world do exciting cases, either because we're interested, or because we want to refresh our memory, or because it's part of our learning. Then we want to perform these cases. We may want to have the support of a surgical coach or a mentor from another country, from our own hospital, our own city, our own country, whatever is needed to help you through that case. But equally, you're recording that case so you can go back and review that to perfect. Again, the recording is optional, but we find that it's very valuable as we work towards video performance metrics. I want to make sure that everyone also understands that there is evidence behind this. I don't want to be here seen as a cowboy delivering some technology that hasn't been evidenced. There are a lot of papers that have published and shown that telementoring is a sustainable model of surgical care. It reduces variation. It improves quality of care. It improves training and education. And it improves flexibility for patients to have access to the care they need without having to travel miles and miles to get that care from different hospitals. We've also published that having Proximie is equivalent to having a rep or support in the room. And the role of video has also been published by Birkmeyer, Varban, Danilo, Nader Francis, and many others who have demonstrated that video can actually accelerate the learning curve and ultimately reduce patient harm because you have to learn on less patients and you have improved the quality of care delivered to patients within that environment. And it was published in Nature recently by Hung et al. From the USC that automated performance metrics will become the future of giving a comprehensive and objective picture of surgeons' skill and support evaluation of surgical performance as well. And so I hope at least there I've demonstrated to you that this move towards a digital operating room, we've been pulling together the building blocks of it, the research, the evidence, the foundations. But we came with Proximie to try and bring this to the fore and try and accelerate the adoption and the delivery of this around the world. And COVID-19, of course, delivered an educational but a care delivery challenge for us as well. And we needed to build urgency and pragmatism into our approach. The challenge of restricted access to clinical environments, uncertainty around the course of COVID, and how do we continue to provide care to patients in these difficult times and complex cases who, I'm sure for many of you as well, have presented late or presented with more complex cancer than we would have ideally liked? How do we foster a culture of collaborative learning and delivery of care through this platform? And we were very pleased that during COVID, we provided unlimited use cases in terms of mentorship and skill transfer, trying to continue educational and trainee programs that weren't available during COVID because of shutdown of operating rooms, supporting the military in their delivery of care in the field where travel was restricted as well, and ultimately global health initiatives, which is something that's very dear to my heart as well. And I'll share with you some case examples. And what we do is very much anchored in the human story. So I hope these stories will share that impact with you. This is Muhammad. This is a 31-year-old patient in the UK who unfortunately presented with metastatic testicular cancer. The cancer had spread around the vessels in his abdomen, a very complex case that didn't respond as well to the chemo as they would have liked. He needed a resection. And in this case, given the complexity and the advanced spread of it, our surgeons would have done this through an open laparotomy. They were very concerned. This was at the height of COVID. This was early April. And they were concerned that this patient spending 14 days in hospital would have severe consequences on him, on his lungs, and the ability and the high chance of him catching COVID and the sequelae of that. Our surgeons are very good robotic surgeons as well as open and laparoscopic surgeons. And so they decided to do this robotically. They wanted to make sure they could get him out of hospital as quickly as possible. But to have this case done robotically, they preferred to have an expert who has done thousands of these dial in with them and work through the case. So Dr. Jim Porter from Seattle, 5,000 miles away, dialed in and worked with our surgeons. They did this case over 6 hours, had a full clear resection of the whole cancer, and the patient went home at day 3. And at day 7 was doing an interview on Sky News. And the power of this solution, this technology, meant that he got the surgery that he really needed, that was afforded and relevant to him at the right time. And you can see how interactive this case can be. Not only was the remote surgeon able to see the operative field, able to see the room and where the equipment was, he was able to put his hands in as well. He was able to virtually reach in, demonstrate and gesture certain anatomical planes that she needed to go through, concern around the aorta, and support her through that case. And you'll see here the discussions that they're having.
All right, so take these little bands right here. This has got to go right here. That's all got to go. There's nothing in there.
And we have other examples, of course. This is Mr. Danilo Miskovic. Some of you may know him, a colorectal surgeon at St. Mark's. Traditionally, he would have to fly to Athens and to other parts as part of the ESCP, the European Society of Coloproctology, to support the training and delivery of cases for complex cancers. Largely working on lap CMEs and other cases, he wasn't able to travel, but we were able to connect him virtually. He was able to sit at his desk with his own laptop and a webcam and virtually reach in. The surgeon in the operating room was able to see this on the stack, was able to interact with the surgeon. This was all very seamless. And you'll see again a video here of that interaction.
Basically, all you have to do is just to go through here now, along this line. There will be the right branch of the middle colic in there, and there might also be a vein a bit further lateral, but that's okay. You can just take them where they.
So he's able to interact. He's able to take the 3D printed DICOM files and put it into the view so they can both see it, and they're working through the operation together. We also supported training by showing flap reconstruction for trauma for many trainees, and we published a number of papers on this. And this is what I was explaining about urology.
Hello, sir. Ben Challiker here from Guy's. Very grateful today we have the Proximie team in our theatre helping us with some telemetry. And here we have next door our Da Vinci SI, and we have our fellows on there. Cara McDermott, just thinning down the dorsal vein complex. Yeah, that's good, Cara. Just go and stay in the wispy stuff there. See if you can just drop it down.
So if you don't have a webcam, you just need to use your laptop and you're able to dial in. And we do hundreds of these a month. We're supporting a lot of educational needs with societies as well, with SAGES in the US for ventral hernia repair, ASGBI and ESCP. And we're now moving to the transaction of augmented reality, communication, and AI. And we have ethics approval where we're now deploying our system in colonoscopy suites around Wales, not only to support the collaboration and training of endoscopists on identification and screening for cancer, but also now leveraging AI that can start to identify the polyps that look abnormal and that the system would suggest are worth biopsying. And of course, this is something we'd like to spread across many countries around the world, and any support interest within your countries, please let us know as well. What I'm proud to say is Proximie was built by a surgeon for surgeons. Our surgeon users and body are always front of mind. We are now in over 250 hospitals globally. We've been used in 35 countries. This year alone, we have done 6,000 Proximie-aided procedures, and we're moving to doing 800 a month. And we've published over 20 articles on the benefits and the use of this technology. We also partner with health systems and hospitals all around the world. And we are continuing to look at expanding and doing a lot more within the Gulf region than what we've done so far. We understand inherently complex systems. We understand how to deliver this technology and deliver this care. And we've also been measuring the carbon footprint benefit that we can have as well. But as a final comment, I'd like to say that what we do is always mapped around the patient and human story. Whilst the technology is very exciting, and the fact that we can do this that was never possible before is empowering, ultimately what we're trying to do is to improve the quality of care, support our surgeons, and ultimately scale surgical expertise everywhere in the world. Thank you very much for your time.